Thirst or desire to drink. How drinking is regulated. Increase plasma osmolality. Number 2, by decrease extracellular fluid volume and by decreasing the blood pressure. What structures or organs are the regulator of thirst? Number 1, there are 4 structures. Number 1, hypothalamus. Number 2, diencephalic subpharyngeal organs, SFO, and in lamina terminalis organum vasculosum. These circumventricular structures, they lie outside of the blood-brain barrier, and they respond to hypovolemia by increase in the activity of the renin-angiotensin aldosterone system. The third structure concerned are the baroreceptors, and the fourth is the dryness of the pharyngeal mucosa. How hypothalamus controls drinking. The anteromedial hypothalamus has osmoreceptors in the supraoptic and paraventricular nuclei which detect changes in the plasma osmolality. An increase in body fluid osmotic pressure initiates the process of thirst and drinking. How hypovolemia stimulates thirst. The hypovolemia stimulates thirst by stimulating the baroreceptors. How many types of baroreceptors are there and what's their location? The baroreceptors are the strep receptors. There are 2 types of baroreceptors, the low pressure and a high pressure system. The low pressure receptors are in the great vein, atria, and pulmonary circuit. The high pressure systems are in the carotid sinus and aortic arch. Which of them is the main mediator of thirst? If volume is low but BP is normal, then low pressure stress receptors send impulses to cause vasopressin secretion. If both volume and blood pressure are low, high pressure system sends impulses to cause vasopressin secretion. So low pressure system is sensitive to moderate changes in volume and is the main mediator of vasopressin secretion. In hypovolemia, baroreceptor act by producing angiotensin 2 via renin-angiotensin aldosterone system that act on SFO and OVLT of lamina terminalis and sends impulses to hypothalamus to drink water. How hemorrhage stimulates the thirst. Decrease in extracellular fluid volume due to hemorrhage does not change the plasma osmolality. Hemorrhage causes more increase in vasopressin secretion than plasma hyperosmolality. So what's normal plasma tonicity? The normal plasma tonicity is 280 to 280 milliosmoles per liter with a range of 275 to 290 milliosmoles. A 1 to 2 degree change in tonicity senses the change. The average osmotic threshold for thirst is 295 milliosmoles. At normal osmolality, the ECF and ICF intracellular fluids are in a state of isotonicity. So what's a isotonic state? In isotonic states, the solutes on both sides of the membrane have equal concentration and the net movement of the water is zero. What happens when there is decreased volume? When there is decreased volume, there is increased osmotyl concentration. So if the interstitial fluid has a higher concentration of solutes or hypertonic, as in hypernatremia, then the intracellular fluid, then it will pull the water out of the cell and it will shrink. The cell will shrink, and what are the effects of contracted intracellular fluid? Most of the features of the contracted intracellular fluids are due to hypernatremia are neurological. There is increased risk of subarachnoid and intracerebral hemorrhage, altered mental status, neuromuscular irritability, weakness, and local neurological deficit. Seizure may also occur. If the interstitial fluid has become less concentrated or hypotonic, then water moves into the cells and the cell swells and rupture and cell lysis occur. And what's tonicity? Changing the concentration of effective osmoles in and out of the cells determines the tonicity, and that causes water movement on either side of the cell membrane. Tonicity is regulated by the water balance. It is the water that moves in and out of the cell. Intake or excretion of water adjusts plasma tonicity. Extracellular fluid volume is regulated by sodium balance. 85 to 90% of sodium is extracellular and is the major extracellular electrolyte. And inside it's the potassium. And how it is done? It is the sodium potassium ATPase pump on the basolateral surface that pulls the potassium against the concentration gradient into the cell and sodium out of the cell. What's the marker for clinical tonicity? The marker for clinical tonicity is extracellular sodium, but potassium also plays a major determinant of tonicity. Hypovolemia. What's the effect of decreased body water? Decrease in body water increases the sodium concentration that causes a brisk sense of thirst and decrease in renal water excretion by increase in vasopressin secretion. What's the effect of decrease in sodium concentration? Decrease in sodium concentration increases the renal water excretion by suppressing the vasopressin. So, what's the role of kidney in water balance? Principal determinants of renal water excretion is vasopressin. In hypovolemia, it has the ability to concentrate urine and conserve water, while in hypervolemia, it produces more dilute urine than plasma and causes excretion of excess water because collecting duct becomes impermeable to water in the absence of vasopressin. And number 3, it maintains the sodium and solutes concentration. How kidney controls body water and sodium? To maintain a steady state, how much urine must be excreted daily and why? 500 milliliter of urine per day should be excreted normally daily because normally 600 milliosmoles per day of the solutes must be excreted and the maximal urine osmolality can go up to 1200 milliosmoles. So how is it done then? This is done by filtration. Number 2, by active reabsorption of sodium without water in the thick ascending limb of the loop and also to some extent in distal tubules. And number 3, maintenance of a dilute urine in the absence of vasopressin, making the collecting duct impermeable to water. Abnormalities of any of these leads to impaired water excretion and eventual hyponatremia. What's the kidney response to hypovolemia? If there is hypovolemia, there is a decreased GFR, glomerular filtration rate. And how does it do it? Number 1, afferent arteriolar vasoconstriction and increased sodium reabsorption in proximal convoluted tubules and the collecting ducts. Increased sodium reabsorption in proximal tubules occurs due to increased angiotensin 2 and increase in sympathetic activity. So what does the angiotensin 2 does? Angiotensin 2 increases proximal tubular sodium hydrogen exchange, thereby increasing the sodium reabsorption. And how does the sodium reabsorption in the collecting duct occur? The sodium resorption in collecting duct occur due to increase in aldosterone, increase in vasopressin, and decrease in atrial natriuretic peptide. So, of the total sodium, 99% is reabsorbed, only 1% is excreted. Of that, 70% is reabsorbed in the proximal tubule and 24% is reabsorbed in the thick ascending segment without water, and 5% is absorbed in the collecting duct. This is the collecting duct portion where aldosterone, vasopressin act. So the aldosterone produced by the zona glomerulosa of the areolar cortex bind to receptor on the collecting duct, increases the activity of the sodium potassium channels on the apical membrane, and sodium potassium ATPase pump on the basolateral surface. So how GFR is reflected? GFR is reflected by increase in BUN and increase in serum creatinine. Normally BUN creatinine ratio is 10 to 1. But in hypovolemia, BUN to creatinine ratio goes up to 20 to 1. Urea absorption is increased more than the creatinine, but creatinine absorption is also increased. What's the body response to hypovolemia? Loss of blood, vomiting, and diarrhea or hypovolemia leads to activation of the RAAS system, catecholamine release, and vasopressin release. All these three factors causes vasoconstriction, increased volume, and cardiac stimulation. When there is a blood loss, it causes decreased arterial pressure and altered blood gases. That leads to the decreased arterial pressure stimulates the baroreceptor, and altered blood gas stimulates the chemoreceptor, and they cause cardiac stimulation, vasoconstriction, and flow and volume redistribution. The vasoconstriction and tachycardia triggers the thirst for both water and salt via renin-angiotensin system. Angiotensin 2 travels in the blood until it causes ADH release from the posterior pituitary. What's the body response to hypernatremia or hyperosmolality? Hypernatremia is when sodium level is more than 145 millimoles per liter, and this may be due to increased sodium or decrease in water. Majority of cases of hypernatremia are due to decreased water. Hypernatremia leads to intracellular fluid volume contraction. So what's the response to hypernatremia? It's a thirst, increased water intake due to thirst and due to increased vasopressin secretion and excretion of a maximally concentrated minimal urine. The skin water loss. The normal water loss from skin is 500 milliliter a day, and the sodium content of the sweat is 20 to 50 millimoles per liter. Evaporative or insensitive loss of water is important in the regulation of core body temperature. What are the conditions in which there is increased insensitive loss of water? Fever, heat exposure, exercise, severe burns, and mechanically ventilated patient have excess loss of insensitive water. What are the effects of profuse sweating on sodium and water? Sodium content of the sweat decreases with profuse sweating, and this is due to the action of aldosterone. So the sweat becomes hypotonic. Since the sweat is hypotonic, the water loss exceeds the sodium loss and is minimized by thirst. Hyperosmolality leads to intracellular fluid volume contraction, and hypernatremia leads to increased thirst and excretion of concentrated urine due to increased vasopressin secretion. Hyperventilation causes evaporative water loss, especially in mechanically ventilated febrile patients. The GI water loss. What's the difference between vomiting and diarrhea? The gastric secretion is acidic, so vomiting leads to metabolic alkalosis, whereas biliary, pancreatic, and intestinal secretions are alkaline, so diarrhea causes metabolic acidosis. The conditions that decreases the thirst, apart from infancy, They are altered consciousness, postoperatively, physically handicapped, psychosis, intubation, damage to the hypothalamic receptors, cerebral diseases, and a lesion in the diencephalon.